Today I am talking to Freddie Hamdy, Professor of Surgery at the University of Oxford and an expert in prostate cancer, about prostate cancer screening and the implications of the CAP trial. So, Professor Hamdy, why would we want to screen for prostate cancer?
So we have many men in the UK and in the Western world in particular who are diagnosed with prostate cancer. In the UK, it's approximately 47,000 men every year, but we also know that about 12,000 men die from prostate cancer every year. So the purpose of screening really is to try and detect disease which needs to be treated as early as possible in men who don't have any symptoms at all, to detect the disease, decide which disease needs to be treated, and then to treat it early so that we can achieve a cure. The problem we've had with previous studies, particularly in Europe, is that they showed that it's possible to detect the disease very early, but the majority of the disease that had been detected in these studies was what we call indolent disease, so disease which doesn't progress and doesn't cause harm. And as a consequence of detecting this disease, whilst it is possible to save lives, you have men who are treated unnecessarily, and the treatments lead to side effects which are not desirable.
Why did we do the CAP trial?
So the whole purpose of the study was to test what is the value of doing a single PSA test, detect the disease by biopsy, compare the group who receive the testing with another group that don't receive the testing, to see whether it gives any benefit at an average of 10 years in terms of men dying of the disease. So the purpose was to find out whether there's a difference if you had the PSA testing or not. I really think that the most important thing is to try and avoid to diagnose cancers which are not important. Because the minute you diagnose a man with cancer, no matter how small it is, it actually gives a new identity to that man, and it converts a healthy person into a patient. And it's like giving them a new passport, which they will have to carry for the rest of their life. So, this is really what's motivated us to do a lot of that research. We wanted to ensure that the over-detection and over-diagnosis of prostate cancer did not become prevalent in the UK and in the world, and we wanted to make sure that we don't over-treat patients.
What are the main messages from the CAP trial?
The findings from the CAP trial, at an average of 10 years after starting the study, is that there was no difference between the two arms in the number of men who died of prostate cancer. So at an average of 10 years, giving the single PSA test doesn't seem to have made a difference. The really important message behind that in these findings is that it was very clear that the single PSA test detected many men with small volume, low risk prostate cancer, which is unlikely to cause them harm in the long term. At the same time, we have discovered that the single PSA test, followed by the biopsies using transrectal ultrasound guidance, failed to detect a large number of men with really bad cancers, and many of these men died of the disease. So at the same time as a single PSA test detected a lot of men who probably didn't need to know that they had cancer, it missed many of the important cancers. The methods that we used are inadequate to find these lethal cancers and cannot differentiate the good ones from the bad ones. And that's why what we need to do is not stopping to think about screening, but we need to use different methods, a different pathway, including utilizing imaging like multiparametric magnetic resonance imaging, which is now being used increasingly, so that we can help to make the decision whether a man needs a biopsy, even if he has a PSA which is marginally raised. Using our information about the genetics of prostate cancer, that's the genetic composition that each man has, which is different from man to man, using other markers that we can measure in the blood, using this combination of information, we need to answer that main question for individual men. Do I need to be tested for prostate cancer? And avoiding giving a man a diagnosis of a disease that he does not need to know. At the same time, we hope that the new diagnostic pathways are going to be able to identify the really bad cancers which need to be picked up early, needed to be treated well at the very beginning, so that we can really accomplish our main aim, which is to save lives.
So what should a man who is worried about prostate cancer do now?
There are essentially three questions that men ask themselves when they start to worry about prostate cancer. The first question is, do they need to be tested whether they have prostate cancer or not? In other words, they want to know what is their risk of having disease which is going to interfere with their quality of life and with their length of life. That question needs to be discussed with the man's family practitioner or general practitioner to discuss whether there is a risk there. And some of the risks are, for example, a family history of prostate cancer. So if a man has his father, his brother, or his uncle who have had prostate cancer and who have died of the disease, then that man is at higher risk of having prostate cancer, which needs to be detected and probably needs to be treated as well. So there has to be a discussion between the man and his GP about whether they go forward and have a PSA test. Once this is established, then a PSA blood test can be requested by the man. And if the PSA is even slightly elevated, that poses a new question. And the new question is, does that man need to have a biopsy? In other words, a small piece of tissue taken out of the prostate to look under the microscope and to find out whether there is cancer there. And now we have evidence that if we use imaging before the biopsy, we are able to see lesions that we were not able to see before using the previous method of imaging, which was an ultrasound machine that was introduced in the back passage to look at the prostate. These MRIs are able to identify lesions, sometimes in awkward parts of the prostate, which can then be targeted very precisely with a needle going into that lesion, finding that cancer. We also have some evidence that these lesions, when they are visible, are likely to be important lesions that the man needs to know about, and it helps the clinician then to not just to make the diagnosis, but to find out whether they need treatment and what is the best treatment for them. The second question that men need to ask, if they happen to be diagnosed with prostate cancer, is what is the best treatment for that? With this study, we were very fortunate because we had been conducting the PROTECT trial. When we detected prostate cancer, we randomized, in other words, we allocated the man randomly to one of the three conventional treatment options for prostate cancer. And that's either a form of active surveillance, that's waiting and watching the disease very carefully to make sure that it doesn't get worse, but at the same time, not to treat patients who don't need it. We allocated some men to surgery, that's radical prostatectomy, to remove the prostate with the cancer that's in it, or they were allocated to radiation, radiotherapy, which is X-ray treatment of the prostate. So what we found out is that radical treatments actually do work when we give the treatment to the right patient. And although we didn't show a reduction in mortality at an average of 10 years when we compared men who received surgery, radiotherapy, or active monitoring, we were able to reduce the incidence of the cancer from spreading by about 50% in the men who received radical treatment compared to the men who received active monitoring. And this is really good news. We also detected about 400 men with higher risk and advanced disease, which we couldn't include in PROTECT because they had disease outside the prostate, through this single PSA testing. And undoubtedly, these men have benefited from early detection and treatment. So the dilemma we have is that alongside these men who have benefited from early detection, whether they were in PROTECT with contained disease or with advanced disease, many more men were diagnosed with low-risk cancer, which did not need treatment. And this is absolutely what we need to fix. So at this stage, what men need to do very carefully is weigh this difficult trade-off between the possible benefits in cancer cure from early detection and radical treatment and the side effects of these radical treatments on quality of life. We really believe that our studies combined do help with this decision making, although much more research is needed to identify the right man for the right treatment at the right time. The third question is, if the treatment fails, what should happen and what would be the second line, the third line of treatment? And how does it help to prevent the disease from progressing? And this also, there are many advances, and the men who have disease which has failed to respond to the initial treatment have many opportunities now to have the outcomes improved. So these are the questions that any man needs to ask himself if he's worried about prostate cancer. He must have the conversation with the general practitioner about whether they need to be tested, and he must consider the fact that he may receive a diagnosis of a disease which is not necessarily important disease, and that he will have to make difficult decisions about what choice of treatment he is going to need.
What are the side effects of the treatments you are talking about?
If he's found to have prostate cancer, he has to decide what treatment he's going to have. And now, knowing that there is equivalence between the radical treatments that we have demonstrated, the man's decision is going to be based on the trade-off between the side effects of individual treatments and the benefits that he can get in terms of oncological or cancer cure, and what are the chances of this cancer needing to be treated. The risks and the side effects are very different between treatment modalities, and we've reported that before. And every man will have different priorities. Some treatments will affect more the urinary function and the leakage of urine after the operation. If he has surgery, the sexual function, or some men will have symptoms in their bowels after X-ray treatment, for example. The symptoms, some of these symptoms recover, but the man needs to decide what is the priority, because the treatments seem to be equally effective. So sometimes when we find that the man who's been diagnosed with prostate cancer has really a small amount of cancer, that when it's looked under the microscope, it really doesn't look like an aggressive cancer, then it is possible to watch that cancer very carefully, to monitor it with repeat blood tests, with repeat examinations, with repeat imaging, to see whether over time it grows. And the purpose here is not simply to delay treatment, is to avoid treatment which may not be necessary, and therefore avoid the side effects which can come with it.
What should a man do if he has urinary symptoms, in other words, symptoms affecting his waterworks?
We must avoid here a confusion, because many men out there think that they are only at risk of having cancer if they have symptoms. This is not the case with prostate cancer. Early prostate cancer, cancer which is contained to the gland, does not produce symptoms, usually. It only produces symptoms when it really starts to become advanced. At the same time, many men, as they age, and it's a natural process, have an increased size of their prostate, and that causes symptoms. This is a completely benign process. When a man has symptoms, it's really important that he goes and discusses it with his GP. It's really important that these symptoms are investigated. And part of the investigation of these symptoms is indeed to do a PSA test. But it's done for a different purpose, because we know that a PSA test can indicate also benign disease, benign enlargement of the prostate. It can indicate whether a man is at risk of developing problems from that benign enlargement of the prostate, like, for example, getting a complete blockage of the urine, which is quite a painful condition, but it's completely benign and it can be treated. So there are good uses of the PSA test, which are not necessarily to detect cancer. So a raised PSA test is found if the prostate is enlarged, if there is an infection in the waterworks, if a man has the PSA done, for example, immediately after ejaculation, it may cause a rise in the PSA test. If a man is a marathon cyclist, it can cause a raised PSA. And all these reasons are benign reasons for a raised PSA. At the same time, it can be raised in small amounts if there is cancer, if there is the presence of cancer cells in the prostate, because some of that PSA will leak into the circulation. So a raised PSA does not necessarily mean cancer. It raises and it gives us alarm bells that maybe there is a small cancer there and it needs further tests. So it's important to put the PSA test in perspective and not to think automatically that a raised PSA means that there is cancer there.
So what investigations do you offer after a man has a raised PSA?
So if a man is found to have a raised PSA, first of all, we need to find out why he had the PSA measured, whether he has any symptoms in his waterworks, or whether he simply had the PSA because he's worried about prostate cancer, or he has a family history of the disease and his father or his uncle or his brother had that. Now, in the past, as soon as a man had a PSA above a certain threshold, we discussed and offered to that man if he wanted biopsies. And the biopsies are done through the back passage with transrectal ultrasound guidance. So in other words, we place very fine needles in the prostate under local anesthetic. Now, that allows many small insignificant cancers to be identified, and this is exactly what we need to avoid. So there's a new form of imaging which has now been introduced, whereby instead of jumping straight from a raised PSA test to doing the biopsies, it is very helpful to use that form of imaging to try and find out whether we can see lesions that we can target more precisely. And all this needs to be discussed with the patient, because every step gets closer to a potential diagnosis, and it's really important that the man knows what is the next step and what is the step likely to demonstrate.
Are there any risks with doing these biopsies?
Yes, of course. There's no intervention which doesn't carry any risks, and biopsies are obviously, it's an invasive procedure. There's a needle which goes into the prostate. It can cause bleeding, it can cause infection, it can cause blockage of the urine. Some patients even need to be admitted to hospital because of that. And of course, we take all precautions because we do it through the back passage and potentially we contaminate the needle which goes into the prostate. We take precautions. We give antibiotics before the procedure, we give antibiotics after the procedure. We warn the patients that they may get bleeding, that they may get an infection, and they need to get in touch with the doctors immediately if they have a problem. This is also changing slowly in that there is a different way of doing the biopsies, and that's through the skin, but not going through the back passage. And at the moment, most of these biopsies are done under a general anesthetic, but slowly this is also changing so that we can do them under local anesthetic. And as this changes with the new imaging modalities, biopsies are going to become safer, they're going to become more precise, and the risks that these biopsies carry will be less. If you combine that with being able to see the lesions which potentially have cancer cells in it, then I think we're going to have the best outcome, reducing the side effects, getting more precise diagnosis of disease, which is important, and therefore offer treatments that the patients need and overall improve outcomes and save lives.
Professor Hamdy, thank you very much for your time.
Thank you.